Hi, it is my pleasure to introduce my colleague and dear friend, Dr. Stephen Kovacs, who is the director for pulmonary as well as bronchoscopy at UPMC Hammond in Erie, Pennsylvania. We're going to be discussing today the role of the pulmonologist in establishing lung cancer screening and bronchoscopy program in different settings, both rural / suburban and urban settings, the challenges that this causes and the inequities that we have seen in our practice, in our history of practicing, both in Pennsylvania, the state of Pennsylvania and the state of New York, and what these challenges, how can they be overcome, as well as the future. With that aside, it's a pleasure to meet you, Dr. Kovacs. How are you doing today?
Thanks, George. It's great seeing you as well. And yeah, I'm so happy to be part of this talk about such an important topic that it's dealt with so many people across the country, across the world, really. So yeah, I'm excited to start educating on this process.
Sounds great. So let's start with saying, well, you and I, we have started programs in the past in both in the states of Pennsylvania, but we have given national talks on how to establish bronchoscopy programs, and we've seen we're asked all the time from all different sources, pulmonologists in the latest Society of Advanced Bronchoscopy meeting we had a pulmonologist from Guam asking us how to set up a bronchoscopy program in the island and the challenges that happen. And in my expertise, I've asked internationally, like you mentioned, how to bring lung cancer screening and these new technologies that we use here in the US to other countries as well. What has been your experience in establishing this type of technologies and programs in the city of Erie, which is, by all means, it's not a mecca, you would think, but you have been very successful in establishing these bronchoscopy programs and lung cancer screening benefiting the community and beyond.
Oh, thanks. So yeah, when we kind of look at setting up these programs, it really comes down to really kind of several things. First of all, I think people need to understand that how serious lung cancer is. I think when you're championing programs like this and trying to discuss this with your administration, they're looking at every disease process out there. They're looking at things like their cardiac surgical program, their ortho program, and why should we spend this money and spend this time dealing with lung cancer? And what a lot of them don't realize that we do is that lung cancer is still the most deadly cancer worldwide, killing more people than prostate, breast, and colorectal cancers combined. And over 250,000 people every year in the US alone get diagnosed with lung cancer. And unfortunately, up until recently, this was a late stage diagnosis. People aren't seeking care until they get symptomatic. So those from a process standpoint are the ones that unfortunately are the sickest and we can do the least about. So I think as you're championing these programs, having the conversation with your administration for the tools and the people and the techniques you need, really have to focus around three factors. That has to be clinically beneficial, it has to be operationally sound, and it has to be financially responsible. And none of those can really exist without the other. So clinically, again, we talked about how it's how deadly it is, the prevalence of it. Operationally, what tools and people do you need to make this happen? And by obtaining those, what kind of financial benefit can you see with that? So what we found is that from an operational standpoint, what you really need is you need a process. You need the process of capturing these patients, and this is typically through lung cancer screening, which should be a much higher volume process than unfortunately we see, because as you know, only 6% of the people out there who qualify for lung cancer screening nationally actually get lung cancer screening. So the majority of these nodules are found incidentally. So it's having a process in place where you can deal with your incidental nodules in a very judicious and efficient way. And luckily there's lots of companies out there that offer software solutions to help with that. But it's also educating the correct patients on screening and educating the PCPs on screening and why it is so important as part of that. And then incorporating a staff around that. So having a navigator, having a setup and a process through your office so that when these patients are found, they can very easily and judiciously be filtered to you so that you can you can bring them into the fold and have these conversations with them about what the next steps are. Luckily, a lot of lung nodules are benign, but as you know, there's still a very high percentage of them that still are malignant and are best when caught early. So then to catch those early, and really is where we come in, and the fact that we have finally technologies that are out there via robotic bronchoscopy and advanced imaging, and the ability to evaluate tissue in the room with new technologies. Having all that now that we didn't even have 5-10 years ago has really changed the focus in the game of how we're moving this forward. And I think geography, it doesn't really matter as much. Your politics are local, just as your population is local. And you can find ways when presenting your argument to your administration, having these conversations with them to meet all those goals with what works best for you, your hospital, and your patient population. That's, to me, I think the best way to look forward, and how we've been successful at taking that strategy and approach. Similar to what you did up in Brooklyn, correct?
Correct. I mean, that's, you touch on so many great points here. One of the challenges that I see, specifically speaking about underserviced communities, is that one of the challenges that I have, particularly in Brooklyn, New York, is that coming from Pennsylvania, insurance coverage is one of the things that we really didn't talk much about in Pennsylvania because, University of Pittsburgh Medical Center was very much in charge of their own insurance plan, and the health coverage was fantastic. They were back and forth with Blue Cross Blue Shield and other insurances companies, but pretty much that was not really a conversation that we were having. In Brooklyn, it's a completely different scenario. And the conversation every time that the conversation was leaning towards with the administration was like, well, how about downstream revenue? How about the amount of how much percentage of Medicare you have? How much percentage of Medicaid you have? And that really shouldn't change the conversation, but you're absolutely right, it does. And it's important for pulmonologists out there and oncologists and thoracic surgeons to know these numbers so that when you talk to administration, first of all, know the tools that you would need to start this type of programs, but also the type of impact that they can have, even in populations that are underserviced and populations that are maybe having a higher percentage of Medicare, Medicaid, because at the end of the day, you and I know that diagnosing these cancers earlier saves you money, saves the hospital money, increases overall mortality, morbidity, all sorts of things that that are pivotal. And it starts, like you said, with a great, robust lung cancer screening that it's not available right now anywhere in the country, not because of lack of trying. We're still very much trying to get into the collective consciousness of the country and the world, how important lung cancer screening is. And we're still falling short, well short. You said 6%. I would venture to say here in New York, we're less than 3%. With the millions of people, Brooklyn itself, the asset, if you take it as a city, I believe it's like the third or fourth largest in population as a city, if you take Brooklyn as a city in terms of population. So it's a huge community, and it's not, again, well served for the things that we know that work, especially with lung cancer, which is, as you mentioned very well, that it's the highest mortality cancer right now. So what are the things that you could probably you talked about talking to administration, you talk about, creating a network, creating a good stuff. I believe that that's very important. What you mentioned is tremendously, people don't think about that. They don't think about the pathologists that they're going to work with. They don't think about the, like you said, the navigator. They only think about the toy, right? They want, oh, I got a robot, that's it. I can
Right.
go with it. And it's so important. That's, a robot is going to get you so far. If you start, if you don't have the supporting staff and the supporting administration, the supporting crew that goes along with, you're not going to be successful in launching. And it only takes a few bad cases for everything to fall apart, especially if it starts with a shaky, promise. So how would you discuss when, especially young pulmonologists that go out there and say, yeah, I need this to start, because how would you convince an administrator to tell them?
Yeah, no, it's a really good point, George. I think back to when you and I first started, and what little we could do for lung cancer, and everything we found was late. And we were the pulmonologists were kind of the last vestige of lung cancer. So we were kind of the special teams, if you will. And now, to quote, Nick Bassis from back in 2013, his chest editorial, pulmonologists have switched from special teams to quarterback. I think you have to take that mindset, right? So we're the ones still kind of running that team. And the team is not just the team, as you said, for the navigators and rad techs and team in the hospital and your endoscopy units that are helping you do this, all very important. But really, the team is much larger than that. So the team is your local circle, which is the ones you work with directly in your multidisciplinary fashion. So it's getting your thoracic surgeons on board, which they're very much want to be helpful in this. They don't want to have to deal with surgical diagnosis anymore. Nobody wants to take out a lung nodule for a diagnosis. They want to do it with a known cancer, a known early stage, so they can do the best, have the best outcomes for those patients. And the same thing, dealing with your radiologist to flag these and get them down the appropriate pathway. Dealing with oncology, so you have good handoff as part of that. So when the patients are diagnosed, that process is streamlined. You've streamlined what you do in your office, and the procedure, but then afterwards as well. And then from there, it's an outreach program. So the way we started with their team was our referring physicians. A lot of these PCPs out there don't know who to send to. How many times they just get stuck with a patient that has a lung nodule, not even a diagnosis, just a lung nodule that was read by a radiologist said, has a risk for cancer. So all of a sudden that patient gets referred to pulmonary surgery and oncology and interventional radiology and all in the same time. Yeah. So now that poor patient doesn't know any better. Yeah. Right. So education is important. We reached out to all of our referring physicians and really had to myself and my navigator and our team to really kind of educate and say, no, you've got one, you only have to send to one. Like, we're going to make your life easier. We're going to set this up where if you have a nodule, this is the process you go through, whatever that works for the community.
I think that's great that you mentioned that, because the patient sometimes is very, very much lost in this equation. The primary care physician really doesn't know any better. Because they're dealing with 20 different things. Yeah. So really what they want is just one single person that they can deal with. And I agree 100% with you that, as agnostic that we should be, the pulmonologists, we should be agnostic. Obviously you and I think that we're agnostic, but we all have our biases. But, the ability to be able to coordinate. Sometimes nodules, although we think that we can get to any nodules, sometimes the patient's going to be better served with interventional radiology, with the local anesthesia, especially in an early patient with lots of potential complications, anticoagulants, stuff like that, would be better served with an IR guided biopsies. However, they should know that that may not be the last time that they need a procedure. As you know, they're probably going to need some sort of mediastinal staging. They may need the oncologist to give them some ideas of how to treat it. Especially now with the abilities of treatments out there, it's very important to have that coordinated, to have a team that really is not just one person. We're beyond, I believe, the times where you were a single star was doing everything. All the surgeon was taking all the nodules. I think we're beyond that, and we should be beyond that, because as you said, most of the nodules are going to be benign. You're going to have a lot of surgeries that did not need to be, and that's another way to kill a perm, right? If you start sending benign nodules to surgeons and they're like, "What are you sending me?" You have to send me the real things, so that the patient can get the benefit from a surgery, because the surgeries, as even though they're very safe these days, they're minimalistic with the robots and everything, they're still surgeries. They still need admission to a hospital. They still need a chest tube, and very uncomfortable. So I 100% I agree with you. It's a team-based approach, but again, building that team, knowing who is coordinating. I think that you nail it. The pulmonologist is acquiring that role of coordinating all that. We were able to build here in Brooklyn a cancer center with a multidisciplinary approach where the patient comes and the oncologist, the pulmonologist, and the thoracic surgeon is there in the appointment, and we're able to discuss with the patient whether they need to see the oncologist that day or they can wait. They can wait a week or two until we get that diagnosis, and or seeing the surgeon, and the surgeon can explain what the surgery means. So I believe you have the same kind of setting in here in Pennsylvania. I think has been very helpful in guiding that patient, which is ultimately our goal, trying to guide that patient to the best treatment and guidance towards the best diagnostic as early as possible.
Yeah, I agree. I think the the strategy you talk about is sound too, because I think like with everything, when you're from the ground up, you're trying to build, you always have to build a foundation. So if you're championing this program, then you have to start with building around yourself first. So that's getting, staff in your office, your navigators, your stuff set up that they can be part of that outreach program to help bring this volume and to help manage this from start to finish, because we are kind of in the middle of that. We're catching them when they're coming in, and we got to make sure they need to get to where they're going once they're diagnosed. But that early diagnosis is so important. And then when you're having these conversations with administration about these types of programs and about what you need to build into the the fray, it's you start to realize, or they start to realize too, when you have an argument, not just saying I need this because I want to do this, but if you start saying, look, you're going to bring in this FTE, but realizing that once we bring in these patients as part of this, these are patients who are going to stay in the fold, because when they're diagnosed efficiently, if they go through a seamless, efficient diagnostic process where they have a lot of confidence in, those patients will also tend to stay in your program. That was one of the biggest things when we started robotic bronchoscopy in 2018. The one thing that the hospital and the system really looked at was that, and they saw, our volume went up by 40%, but what they were most interested in was when you actually looked at the breakdown of patients coming through. And you remember our system where, in like a lot of places, we had two big hospital systems, and patients would come in, where they go to the hospital they were born in, and that's where they'd stay, and that's where they'd die, and they never go to the other place. What they found was that 20% of the patients underwent robotic bronchoscopy, stayed in the system, and had never once stepped foot in a UPMC, any of the UPMC hospitals until that day. And again, majority of them stayed, and then when they tracked them and followed them, they saw that they started to switch other things over. They not only got their oncologic care there, but they switched to PCP. I started to see a cardiologist at our place, because once they can see what your place looks like and what your program looks like, all of a sudden you now have become the crown jewel of instilling confidence throughout their entire process. And administration really hangs on to that. So then you start showing these growth metrics, and you start showing that just by doing the right thing and moving people along in the way that it should be done, that unfortunately is rarer than we realize. So if you are a program and you're looking to set this up right, you build from that foundation, you build out to that, and you bring those patients in, it will become a process that you're going to continue to be able to build and grow on top of to really do the right thing for this deadly disease for the patients that you're dealing with.
You couldn't have said it better. I mean, that's fantastic. And honestly, that also creates, once you create that program, really there's no need to shy away from taking care, again, the Medicare, the Medicaid patients, creating a strategy for them. What we do here is we tend to admit the patients to the hospital and setting them up, talking to social work, talking to, again, the navigator, discussing with what is the best way to handle those cases. And that way you diminish the inequities that are 100% in the system. But again, every time that I was dealing with a patient under insurers, every time that I got to a doctor for a peer-to-peer or whatever, when I explained what we were doing, it was a no. It was really a no call. It was just absolutely go ahead and do it, because again, at the end of the day, it saves money. It does. It's a really kind of like shortcut too, because we know that these patients, if they're not diagnosed early, if you wait until their cancer is grown, that's when the complications start. That's when you start that's where the money starts pouring in from all sides, and they're not controlled. That's when ICU starts coming in. So you don't want to get to that point, which again, it's the 90s and the early 2000s where you were diagnosed with stage 3, stage 4. We're moving away from that. And again, once you create that program, the inequities, if you think about them, they kind of shy away from that. So this was a great conversation, Dr. Kovacs. I really appreciate you taking the time to discuss this. I hope that if the audience have any further questions, they can reach out to us through Society of Advanced Bronchoscopy. I would like to thank our sponsors for this, and if they had any questions, they can follow up with us, leaving us messages. But thank you again, Dr. Kovacs, for your time. It's been a pleasure.
Thank you, Dr. Mercado. It has been a pleasure.